One second. Yeah. Today, uh, this is this 1 hour session. This 1 hour session. I'm going to cover the very interesting topic. Very interesting topic. That is the name of the topic is unraveling the histopathology of oral squamous cell carcinoma. Unraveling the histopathology of oral squamous cell carcinoma. Okay. Fine. So this topic is a very interesting topic. All of us know about what is the basic meaning of carcinoma. What is the basic meaning of carcinoma? Carcinoma means anywhere it is nothing but the malignancy. Carcinoma means malignancy. And if malignancy arises from the epithelium, we are going to call it as the carcinoma. So malignancy of epithelial tissue, basically, we should call it as carcinoma. So the point important here is that the origin is basically from the epithelium. Okay, all of us know the basic histology. Before exactly going into the histopathology of the oral squamous cell carcinoma, let us understand the some important basic point about any epithelium, any mucosa. Oral mucosa is basically made up of surface epithelium. This is very important. Please try to understand this. A surface epithelium and a connective tissue. So this is the epithelium and this is the connective tissue. In between the epithelium and connective tissue, we have the basement membrane. The red color border which I am showing right now, all of you, is nothing but your basement membrane. This is nothing but your basement. So basement membrane is present between the epithelium and the connective tissue. Okay. So what happens? This is normal. This is a normal tissue. This is a normal tissue. What happens in malignancy, particularly in carcinoma? In carcinoma, this continuity is lost. This basement membrane continuity is lost. So what happens if this basement membrane continuity is lost? If this basement membrane continuity is lost, whatever epithelial cells are there, they will invade into the connective tissue. They will invade into the connective tissue. This process or this mechanism is known as invasion. So when the basement membrane breaks and the epithelial cells enter into the connective tissue, you call this as invasion. Okay, invasion is the most reliable, this is considered to be the most reliable histologic criteria for carcinoma. For carcinoma diagnosis, Invasion is the most reliable histological criteria. Okay, so after knowing this basic concept, that is what is the epithelium, what is present between the epithelium and connective tissue, what is invasion, okay, let us understand it, the histopathology of the oral cancer. The oral cancer or is nothing but the squamous cell carcinoma, and this squamous cell carcinoma basically this squamous cell carcinoma basically, if you see, what does the sentence say? On microscopic examination, all squamous cell carcinomas have an invasive component. They have an invasive component. What do you mean by invasive component? This is what we have discussed now. This is an invasive component. This with a red mark, what I am highlighting, this is an invasive component. This is an invasive component. That is a part of the epithelium that has entered into the connective tissue. That we call it as invasive component. Okay, so all carcinomas will have invasive component where the tumor islands can be seen deep to the surface epithelium. So the tumor islands will be seen deep to the surface epithelium. That means from the epithelium, they will enter into the connective tissue by breaking the basement membrane. Okay, now histopathology, to explain the histopathology, I'll just use a diagram. This is a very important histological diagram we should understand. See, I'll label for you people. This is the epithelium, surface epithelium. This is nothing but your connective tissue. Now, whatever I am highlighting right now are your, all these things are your invasive component. Look at that. Wherever from the epithelium, they have entered into the connective tissue. So this is how a squamous cell carcinoma basically looks like. Under the microscope, the squamous cell carcinoma will show basically invasive component into the connective tissue. Now, exactly how is this invasive component? That is very important. That matters a lot. That matters a lot. Now, we will understand this little more detail. Now, after knowing this basic histopathology, basic diagram of the squamous cell carcinoma, let us understand what do you mean by grading of oral cancer. Grading. See, all of you might have heard in your clinicals everywhere, grading, staging. Okay, staging, all of us. Staging is something very clinical. Grading is histopathology. Grading is histopathological. Now, grading means what? Grading means the degree of differentiation of malignant cells. What now the question comes, what is this differentiation term? What do you mean understand by differentiation? Differentiation in simple terms is a resemblance. Resemblance. Okay. More the resemblance, more is the differentiation. Now you will ask, what is resemblance? Resemblance means there should be two things to compare. We are comparing. Now, for example, a child might resemble a father, or a child might resemble like a mother. That is called as a resemblance. Now, here we are comparing the tumor tissue with versus the normal tissue. Normal tissue. Now, what is a normal tissue in the oral cavity? All of us know normal tissue in the oral cavity is your stratified squamous epithelium. Stratified squamous epithelium. That is our normal oral epithelium. If, now comes the thing, remember, if the tumor shows maximum resemblance to the normal tissue, you will call it as more differentiated. or well differentiated. Well is a word used for more differentiation. It looks like more. It looks like more of the normal epithelium. Okay. So now here, coming back to the discussion here, after understood this, what is the grading meaning? Grading means the degree of differentiation of the malignant cells. Now, what is differentiation? It is the degree of resemblance. Resemblance. So more the resemblance, you will call it as more differentiated. More differentiated. Now here, let us understand that this grading has been given by two people, that is broader. The most important grading system that is very widely used is the Broader's grading system in the year 1920. Try to understand this. Person called as Broader in the year 1920 only, earlier, he has given a grading for oral cancer. Now the WHO has implemented or used the same. WHO has used the same, advocated the same. So Broader's grading system is still now followed. Okay. How did Broader classify? Now Broader classified basically the oral cancer into three: well, moderate, and poor. Well differentiated, moderately differentiated, poorly differentiated squamous cell carcinoma. What do you mean by well differentiated? Well differentiated means more resemblance. If the tumor resembles maximum to the normal oral epithelium, you are going to call it as well differentiated. If the tumor shows less resemblance, then you are going to call it as the poorly differentiated. Okay, so that is very important. You have to understand what is well differentiated, what is poorly differentiated. Overall, here, very important point you have to understand. Generally, the oral cavity maximum is moderately differentiated. 60% of the cases are moderately differentiated oral squamous cell carcinomas. So this can be a very potential point you have to remember, which can be asked as an MCQ in any of your entrance examinations. Which is the most common among all the is well differentiated, which is 60%. Around 30% is the well differentiated, 60% is moderate, 30% is well, and only 10% rare is poorly differentiated squamous cell carcinoma. Okay, so that is about how basically Broader has classified. And what is the incidence? How many cases you usually see the moderate, how many cases you will see the well, and how many you will see the poor, that is incidence wise. Now after knowing this basic about exactly, we will see when I will call it as well. Histologically, what are the criteria, what are the features which I will look for to call it as well differentiated, well differentiated. Now, basic point I want you to understand. Don't see so many things are there. Such a big paragraph is there. Don't get confused. It is very simple. It is very simple to understand. Now, understand what is the basic function of a normal epithelium. Normal epithelium basic function is to produce keratin. So, normal epithelium, if you take its function. Its function. What is its function? Its function is to produce keratin. It will produce keratin. To produce keratin. Now, if I am telling a tumor as well differentiated, that means it is showing maximum resemblance to the normal parent tissue, it should also produce keratin. So, well differentiated squamous cell carcinoma, which is showing maximum resemblance to that of the normal parent tissue, should also show the presence of keratin. Should also show the presence of keratin. So now here, that is what the paragraph tells, that in a well differentiated, it is easy to identify that tumor originates from squamous epithelium since it shows considerable amount. I want you to understand this. Considerable. What do you mean by considerable? Very much. Maximum amount of keratin. So well differentiated will show maximum amount of keratin with the evidence of stratification. Normally we see that in normal epithelium you will see stratification. There are layers: stratum basale, stratum spinosum, stratum granulosum, stratum corneum, right? You are seeing those layers. Okay, even well differentiated squamous cell carcinoma will show layers. It will show stratification. It will show stratification. So it will show maximum amount of keratin production. It will show stratification. These are some important points you have to remember. Let us, still more are there. I'll just discuss. So in this paragraph, what we have understood, that it will produce maximum keratin. Stratification is retained here. Okay. Often the islands of tumor contain central eddies of keratin referred to as keratin pearls. So the tumor, suppose this is the tumor, we will see this in detail using a diagram. So just schematically understand that this is the, suppose this is the tumor island. Now this tumor island basically will contain, this tumor island will contain keratin like this. It will contain keratin like this. Central, this is called as eddies of keratin. And this is nothing but your keratin pearl. This is nothing but your keratin pearl. So the tumor contains lot of keratin. How exactly it is arranged? It is arranged in the form of keratin pearls. There is a cohesive invasion pattern. Cohesive invasion pattern. So this word is very important. I want you to concentrate on this. Cohesive invasion pattern with intact large branching reticulus pushing into the underlying connectivity. What do you understand by this term? Cohesive invasive pattern. That means, suppose this is the epithelium. This is the epithelium. Now here, what the sentence tells, that in well differentiated squamous cell carcinoma, the epithelial cells which have invaded into the connective tissue will be cohesive like this. They will be cohesive like this. What do you mean by cohesive? They are attached to one another. They are basically attached to one another. That is called as cohesive nature of the well differentiated squamous cell carcinomas. Cohesive nature of the well differentiated squamous cell carcinoma. Okay, I hope you have understood about this point, that cohesive nature means the cells are connected to one another. The cells which have invaded into the connective tissue, they are connected to one another. That is called as cohesive pattern. Cytological atypia or dysplasia may not be prominent. That means, what is dysplasia? Already we have discussed. Dysplasia means the disturbed cellular arrangement and orientation. So disturbed cellular arrangement and orientation is called as dysplasia. So in well differentiated squamous cell carcinoma, dysplasia may or may not be present. May or may not be present. Okay, that is important. So it is not must. Usually it will not be prominent. Usually it will not be prominent. So to concise, what are you going to see in well differentiated? In well differentiated, I am going to see more of keratin in the form of keratin pearls, in the form of epithelial pearls. There are something called as epithelial pearls, and in the form of individual cell keratinization also. What do you mean by that? Suppose I draw a cell like this, one cell. Its cytoplasm will be totally having keratin like this, and in the center somewhere you'll have nucleus. So this is called as individual cell keratinization. So there will be increased keratin. It can be in the form of keratin pearl. It can be in the form of epithelial pearl. It can be in the form of individual cell keratinization. It can be in the form of individual cell keratinization. So there is increased keratin. There is cohesive nature, cohesive invasion pattern. Okay, and there will be less prominent dysplasia. So please remember all these three very important points about the well differentiated squamous cell carcinoma. Okay, now I'll show you an image of well differentiated squamous cell carcinoma. You can see this. So this is a well differentiated squamous cell carcinoma, where if you can just see, zoom it and see that. Look at this. Look at this. What are you seeing? You're all seeing the islands of the cells with the keratin within it. So it will show keratin like this. It will show keratin like this. So that is nothing but your keratin pearl. That is nothing but your keratin pearl. So more the keratin, it is easy to diagnose that this is a well differentiated squamous cell carcinoma. Well differentiated squamous cell carcinoma. Now moving on to moderately differentiated squamous cell carcinoma. Moderately differentiated squamous cell carcinoma. So moderately differentiated shows a greater degree of cellular atypia. Atypia meaning dysplasia. Compared to the well, this will show more of atypia and less evidence of keratinization. That means there will be very few keratin pearls. In moderate, compared to the well, it will have less keratin pearls, more dysplasia, and it will have less cohesive invasive front. What do you mean by invasive front? The cells which are invading into the connective tissue, they are called as invasive front. Now, if they are adhered to one another, very close, cohesive, that is called as cohesive nature. In well, it will be cohesive, whereas in moderately differentiated squamous cell carcinoma, they will have less cohesive nature. What do you mean by cytological atypia? Meaning of cytological atypia, I'll just go little explain about the cytological atypia. See here, we will see bit of this because this is a very important thing you have to understand. Cytological atypia means has basically two things. It will have certain morphological changes. It will have certain morphological changes. It will have certain cytological changes. I'm just going out of the just deviation from the topic, but just this is very important because to understand cancer, histopathology of cancer, we should know what is this atypia. Morphological as well as cytological. Morphological means what? If the ridges are drop shaped, that is called as a morphological feature of dysplasia. If there is acanthosis, what do you mean by acanthosis? Acanthosis means thickening of the spinous layer. We know the stratum spinosum, right? That stratum spinosum becomes thickened. Then you call this as the acanthosis. Then next, keratinization is a morphological feature, like keratin pearls you can see in dysplasia. Okay, that is again the morphological feature of dysplasia. Okay, then irregular stratification. Irregular stratification. Normally, how you will see stratification, right? Stratum basal, spinosum, like that. That stratification itself is lost. That is a morphological feature of dysplasia or atypia. On the other hand, cytological features means like first and most important, nuclear hyperchromatism. Suppose this is a cell. How is the nucleus going to become? Nucleus is going to become something like this. Very dark nucleus. That is called as nuclear hyperchromatism. Okay. Then nuclear pleomorphism. What do you mean by nuclear pleomorphism? Nucleus shape will be different. Pleomorphism means different. Some cells will have round nuclei, some will have ovoid, some will have spindled nuclei. That is called as nuclear pleomorphism. Similarly, cellular pleomorphism. Cell shape itself will change. That is called as cellular pleomorphism. Okay. Then an iso an isonucleosis, an isocytosis. What's the meaning of this? Anisonucleosis, anisocytosis. Abnormal variation in cell size, nuclear size. Suppose one nucleus is large, one nucleus is very small. I will call it as anisonucleosis. If one cell is very large, one cell is very small, I will call it as anisocytosis. Anisocytosis. So nuclear hyperchromatism, nuclear pleomorphism, cellular pleomorphism means shape. Okay, remember, if shape changes, I will call it as nuclear pleomorphism, cellular pleomorphism. Then what else? Anything else you will have? We will have the abnormal mitotic figures. So the mitotic figures will be abnormal. That is again a very important cytological feature of dysplasia. Cytological feature of dysplasia. Okay, there are many. So here I am telling you the most important one which we are supposed to remember. That which are the various cytological features of malignancy. So we have seen morphological features, we have seen cytological features. If these features, whatever cytological features of atypia, also known as dysplasia. Remember, atypia is also known as dysplasia. Both are same. Atypia is nothing but dysplasia. If you see less of these, then it is well differentiated cancer. If you see more, then it is a moderately differentiated squamous cell carcinoma. Okay, I'll just show you an image of this. Look at this image of moderately differentiated. You can see here there are so less keratin. I'll just focus one area. This is one area where you can see keratin. And look at the epithelium. It is showing so much of atypia. So there is more of atypia and less of keratin in case of the moderately differentiated squamous cell carcinoma. Now I want you to compare this image and the image. Look at this image. So much of keratin is there. That all pink color, whatever I have just shown to round off, just to border that, there are so many you can see. All those are keratin. So more the keratin, more it is well differentiated. Whereas in moderately differentiated, you will have very less keratin, more of atypia. What about poorly differentiated squamous cell carcinoma? Poorly differentiated squamous cell carcinoma is one which show little or least resemblance. Please remember, least resemblance. Okay, that is why we call it as poorly differentiated. So when I say least resemblance, I can say that exactly opposite. I mean, differentiation means what? Extent of resemblance. More differentiated means well differentiated. If resemblance is not there at all, you call it as anaplasia. Anaplasia is nothing but lack of differentiation. So logically speaking, poorly differentiated squamous cell carcinoma is the one which will show more anaplasia. compared to the well and compared to the moderately differentiated squamous cell carcinoma, poorly differentiated squamous cell carcinoma is the one which will show more of the anaplasia. More of anaplasia. Okay. Now, it also shows pleomorphic cells. That is what we have seen. Atypia. More of atypia. See, I have told you three things. You should see keratin, you should tell about the dysplasia, and you should talk about the cohesive nature. Here, there is a totally no keratin, minimal keratin. You can say no, not at all. No keratin at all. And you are seeing more of atypia, more of abnormal cells, and totally non-cohesive pattern. Sometimes you see that is what we have seen. In case of they will be abnormal. That is why you use the word anaplastic or undifferentiated. Anaplastic or undifferentiated squamous cell carcinoma. I'll show you an image of this. You can see here, this is an image of the poorly differentiated squamous cell carcinoma, where you can see here, this is a mitotic figure. This is a tripolar. It is called as tripolar. Sometimes the mitotic figure is nothing but your chromatin. So that sometimes will have tripolar, quadripolar. So that is nothing but your mitotic figures, abnormal mitotic figures. Look at the basically the abnormal cells here. Look at the abnormal cells here. The abnormal cells the abnormal cells basically are showing all the features of dysplasia. Dysplasia. Okay. Now, so last, I'll just finish off this session with one important variant of verrucous carcinoma. I mean, variant of squamous cell carcinoma known as verrucous carcinoma. Known as verrucous carcinoma. So this verrucous carcinoma is one which has got broad bulbous retroedges like this, and surface has got lot of keratin plugging. So this is what I am talking about, is verrucous carcinoma. So verrucous carcinoma is the one which shows keratin, parakeratin plugging. On the surface, it will show parakeratin plugging. That means more keratin. Then it is showing retroedges which are elephant foot, broad and bulbous retroedges. Those retroedges are called as elephant foot retroedges. Whenever you use the word broad bulbous, you call it as elephant foot retroedges. Elephant foot retroedges. Remember, the important point about this particular carcinoma is verrucous carcinoma is that the basement membrane is intact. Basement membrane is intact. Please remember, this is a very important point. Now comes the question, if basement membrane is intact, that means there is no invasion. Yes, in verrucous carcinoma there is no invasion. In verrucous carcinoma there is no invasion. Then why are you calling it as carcinoma? You are going to call this as a carcinoma because of its unique exoendophytic growth pattern. That means exophytic nature, endophytic. Exophytic means surface, endophytic means inside. So this verrucous carcinoma on the surface is showing parakeratin plugging, and inside it is showing broad bulbous retroedges. Now comes the question, what will happen if they are broad bulbous? Then why are you calling it as endophytic? Because these bulbous retroedges, they are growing downwards. That is called as pushing borders. The verrucous carcinoma will have pushing borders. That means, suppose the retroedge initially was here, okay, after some time, some days or some months, it will become like this. It is pushing downwards into the connective tissue. This is called as pushing borders. This is called as pushing borders. Remember, here the basement membrane is intact, but the retroedge is pushing. Because of this particular growth pattern, exoendophytic. That is, exophytic is parakeratin plugging. Exophytic, when you use the word surface. Endophytic means which is inside. It is having a surface parakeratin plugging, and inside it is showing the pushing borders, you call this as verrucous carcinoma. If you look at the dysplasia here, there is minimal or no dysplasia. There is minimal or no dysplasia. Please remember that there is minimal or no dysplasia. So with this, can we tell that verrucous carcinoma is, if I have to grade well, moderate, poor, under which grade it will come? Under which grade it will come? More keratin, minimal or no dysplasia at all, there is no invasion at all because the basement membrane is totally intact. It is showing pushing borders or pushing margin. See, MCQ can come on based on this also. Which carcinoma shows pushing border or pushing margin? Based on this, you call it as verrucous carcinoma. So if have to match here with the grade, I will definitely match, or I will say that this is a type of well differentiated squamous cell carcinoma. Actually, it is not squamous cell carcinoma. Well grade, well differentiated. Remember, the complication of this verrucous carcinoma is that the verrucous carcinoma can get converted into oral squamous cell carcinoma if it shows invasion. So in course of time, if the verrucous carcinoma shows invasion, then finally it will get converted into oral squamous cell carcinoma. That is what I want you to remember about the verrucous carcinoma. So verrucous carcinoma, again, histopathology is very unique. We are supposed to understand about this. There are many other variants. There are spindle cell variants of squamous cell carcinoma, basaloid variant of squamous cell carcinoma. Okay, that's all rare. Usually we don't see this. Verrucous carcinoma is very common. Verrucous carcinoma is a very common tumor that we come across. Okay, very common malignancy that we come across. So that is about the verrucous carcinoma. So with that, I try to give you an important overview of the histopathology of oral squamous cell carcinoma. So actually, strictly speaking, this is a very important concept. There are certain, if you understand this concept, you can solve many MCQs. Okay, you can based on this, you can better understand. Even see, why is this important? Again, the question comes, what is the need to know that this is well differentiated, this is moderately differentiated? What is the need? The need is that it depends on the treatment modality. Well differentiated, you follow a conservative approach. For a poorly differentiated squamous cell carcinoma, more aggressive surgical approach is followed. Again, the prognosis also is well differentiated, will have good prognosis compared to that of the poorly differentiated. Poorly differentiated will have less poor prognosis. There is a more chances that there will be lymph node involvement, metastasis, and hence the prognosis in case of poorly differentiated will be less or poor. So that is the reason how you have to, and that is the reason why you have to understand the grade of squamous cell carcinoma. That is the Broders grading that has been given, well, moderate and poor. That has been advocated and implemented same by even WHO. There are many other grading system. There is one another famous called as Bryan's grading system. There is another called as Aneroth grading system. Okay, that is not important for us. That is not that important for us to right now to understand. Broader has been followed by WHO. You have to understand the criteria, what is well, what is moderate, and what is okay. I hope I have made I have made this topic a bit easy to understand. Okay, thank you so much for your patient listening. Any doubts, you feel free. Please type it in the chat box. So I comment. I'll definitely reply to your doubts. Thank you.